Hi there, my name is Roger Pillemer. I'm an orthopaedic surgeon with a particular interest in impairment assessment. In the last talk, I discussed the importance of testing for the medial hamstring reflex as a sign of L5 nerve root involvement. If this is in fact the case, I would like to suggest a routine method of testing for the more commonly involved nerve roots L4, L5 and S1. We will be testing for 6 reflexes, 3 on each side, 6 sensory dermatomes, 3 on each side, and 6 tests for motor power, 3 on each side. So this is then testing for the knee reflex, L4, the medial hamstring reflex, L5, and the ankle reflex, S1. Moving to the left side, knee reflex, and I find this a more sensitive way of testing for this reflex than with a patient lying on the couch. And again, I find the best way of doing this is with the knee slightly less than a right ankle and the hip abducted, flexed and externally rotated, and it's done similarly to testing the biceps reflex with the examiner's fingers over the tendons and then striking the examiner's fingers. And S1. Then testing for motor power, inversion, L4, extension and of the big toe, L5, eversion, S1. On the left side, inversion, L4, L5, S1. Sensory testing, L4, L5, S1. Left side, L4, L5, S1. So the clinical picture for an L4 nerve lesion would be depressed or absent knee jerk, sensory loss on the medial leg and foot, weak inversion. For an L5 nerve root, depressed or absent medial hamstring reflex, loss of sensation of the dorsum of the foot going towards the big toe, weak extension of the big toe. S1 nerve root, depressed or absent ankle jerk, sensory loss on the lateral border and sole of the foot, and weak eversion. In summary then, I have discussed a routine method of testing for radiculopathy of L4, L5 and S1 nerve roots. This is discussed in more detail in my YouTube series, as well as a number of other clinical signs and items of interest. Click on the link below. Stay well.